We'll call it a special edition of From Belly to Baby, but this is really from belly to baby to adult. There has been so much information in the news this last week about congenital heart disease, and we've received on this campus a number of questions from people who are concerned about the situation that we all saw unfold so passionately on Jimmy Kimmel. I believe it was on Monday night, when he talked about his infant son being diagnosed with a congenital heart defect immediately after birth. And obviously extraordinarily scary for that family and for any family who goes through it. So we are here today to talk to a number of physicians who see patients with congenital heart disease before they're born, as they're growing up, when they go on to have children themselves, and as they are leading everyday adult lives. So I'm going to let these physicians introduce themselves, and we will acknowledge the empty seat here on the end. We have one more physician, a pediatric cardiothoracic surgeon, who is actually in the OR right now, who is going to hopefully join us and sneak in a couple of minutes. But in the meantime, thank you all so much for making time for this today. Again, so many questions coming in, and we invite people to submit questions live in the comment section of this post. But as we get going, I think it would be a really good idea just to give people some knowledge about what you do and what you see. And Dr. Lee, we'll start with you because you take care of children with congenital heart disease before they're born.
Yes, so I'm Dr. Caroline Lee. I am a pediatric cardiologist with a special interest in fetal cardiology. I'm the director of the Fetal Heart Center at St. Louis Children's Hospital, Washington University. So that's my main thing, is making diagnoses or looking at the fetal heart and making diagnoses of congenital heart defect in utero.
And we'll talk a little bit about what congenital heart diseases can be detected before birth, how they're detected after birth, and so on as we go forward. And Dr. Lindley, you're kind of on the other side of what Dr. Lee is doing. You take care of women as they are in their teenage and into adult years in particular, with the number of issues that come up for them specifically with congenital heart disease.
That's right. My name's Catherine Lindley, and I'm an adult congenital cardiologist. And my interest and expertise is really in taking care of young adults who have congenital heart defects, and particularly as it relates to their reproductive years. So helping guide them through making decisions about family planning and helping guide them through their own pregnancies and then on into adulthood.
All right, and Dr. Billadello, you're taking care of all the grown-ups, as we say at the Children's Hospital.
Dr. Joseph Billadello. I see Dr. Lee's patients when they turn somewhere between 18 and 21.
And
we take over their care.
And we'll stress that all of these physicians know each other pretty well, because the continuum of care, and it's really an amazing thing, and it's something that I think we should highlight early, is that congenital heart disease is not, and I don't know another way to say this, but it is by no stretch of the imagination a death sentence anymore. These people who are born with congenital heart diseases are living very long, full lives, correct?
Correct.
All right, so they need a lot of care as we go, and like we mentioned, there is a pediatric cardiothoracic surgeon who will hopefully be able to join us in a little bit, but in the meantime, let's start with a basic definition. Dr. Billadello, can you tell us what is congenital heart disease?
Congenital heart disease, by definition, is heart disease present at birth. Distinguish it from acquired heart disease like coronary artery disease, which causes heart attacks, that is developmental and comes on later in life. Congenital heart disease you're born with, and you'll have the diagnosis for the rest of your life. And we divide it into mild, moderate, complex forms. Many of the moderate, complex forms will need care for their entire life. That's why adult cardiologists it's important to have adult cardiologists knowledgeable to be able to take care of these patients once they're no longer in the pediatric age range. And that's what Dr. Lindley and I do.
All right, and so before we get to the point that you have an adult with congenital heart disease, you have a baby who is born with a congenital heart disease. And just a couple of weeks ago, Dr. Lee, we had you on talking about a fetal echo and things that you can identify before a baby is born. So let's go to that very initial phase. You find out you're pregnant, you go in for a 20-week ultrasound, and there is a look at the heart. At that point, are these issues often diagnosed? What can doctors see at that 20-week ultrasound that would indicate whether or not something bigger is coming down the pike?
Yeah, the 20-week ultrasound is a really exciting time, and I know you went through that. Most people are interested to find if they're a boy or a girl, but they're also looking at all the organ systems, including the heart. And congenital heart defects are, as we talked about a couple weeks ago, the most common birth defect. So off that 20-week ultrasound, it is recommended by professional medical organizations that the 4 chambers of the heart are seen, but also looking at the outflow tract, so the great vessels, 2 of them that leave the heart and go to the lungs and the body. So those are kind of at least the minimum criteria that at the 20-week ultrasound, obstetricians and sonographers should be confirming. By looking at those 2 important views, at least, most, and certainly most all of the critical heart defects can be diagnosed. And critical being defined as those that will require intervention as a newborn baby, so soon right after birth, or within the first 6 to 12 months of life.
And what is the benefit, and we talked a little bit about this before, about you can't necessarily, I mean, you're not likely to perform heart surgery on a fetus, but what are the benefits of having that advanced knowledge?
So there's the very practical aspect of delivery planning, so having a safe delivery for the baby in the best place that is close to where the baby may receive cardiac care. So to avoid, for example, if you find out after birth and you're at a local, your local hospital, but your pediatric heart center is miles or hours away, that could, if it's diagnosed after birth, mean a transfer for the baby and separation from the mother and baby. And I think that's very difficult for any family to be apart from their newborn baby, and the baby may even need an intervention before the parents can even get to be with them. So one of the practical advantages of a prenatal diagnosis is to make sure that the baby is born in a place where the mother and father can be near, where the baby's going to require surgical or other intervention.
And Dr. Lindley, you're seeing a lot of these moms, and you, as you mentioned, you care for patients throughout adolescence and into adulthood, but when you're seeing, say, a young woman who was born with a congenital heart disease, what is it that you're advising her to do? Because is she then more likely to carry a baby with a heart defect, or how does that work?
Yeah, so I mean, the good news is that about 90% of babies born with congenital heart defects grow up to become adults, and then many of those women end up wanting to have their own children. And fortunately, with appropriate obstetric and cardiac care, the majority of those women can go on to have safe and healthy babies, safe pregnancies and healthy babies. But each woman's risk of a pregnancy is very different than any other's risk. So for some people with very simple congenital defects, their risk is really not much higher than the average population, whereas other people will require really specialized care throughout the pregnancy. And as you mentioned, it is important that that mom is also counseled on the risk of her baby having a congenital heart defect. And in general, that risk is slightly increased. It's approximately 5% risk that her baby will be born with a cardiac defect, as compared to about 1% risk for the general population. So for those moms who have congenital heart disease themselves, we do recommend that they get a specialized fetal echocardiogram during the 2nd trimester, which is performed either by a maternal fetal medicine specialist or a pediatric cardiology specialist like Dr. Lee, who takes some really specialized pictures of the baby's heart to ensure that the baby, usually to ensure that the baby doesn't have any defects, or to identify them early if they do.
All right, and you mentioned the maternal fetal medicine aspect of the fetal echo, but I also know that a lot of the 20-week ultrasound, which is, as you mentioned, so exciting because you have the possibility of learning so much about whether or not you're having a boy or a girl, and for the vast majority of people, that's the net of that appointment. However, for the physicians who are treating them, it's so much more information that they are gathering at that point. And I know that here, from personal experience, you go into an ultrasound and someone from maternal fetal medicine is reviewing that 20-week ultrasound. That may not be the case if you don't have access or choose to go somewhere other than a major medical center. So how would you counsel, and I put this question either to Dr. Lindley or Dr. Lee, how would you counsel a patient who is looking at their options for care in that 20-week ultrasound? Is it necessary to go to a major center, or are there questions you can ask your own OB to ensure that anything that can be caught early is?
Well, I would say certainly for moms who have congenital heart disease, I do strongly recommend that they're seen at a major medical center that has both cardiologists and maternal fetal medicine specialists who are experienced in taking care of these problems, because as I mentioned, there's a really wide range of risk, and so you want to be with someone who's going to be really comfortable in knowing what that patient's risk is and how to identify any potential problems. And then if a mother is seen at a larger medical center and their fetal echocardiogram is normal and they're deemed to be low risk for delivery, then we oftentimes can allow them to go ahead and deliver with their general obstetrician at their local hospital. But I think it's important to at least get that consultation at the high-risk center to make sure it's going to be safe for them to deliver at their local hospital.
And we did have, an OB was telling me this story earlier today about how someone came into her office on Tuesday or Wednesday right after the monologue on Monday, and she was panicked, and she said, how do I know that my baby doesn't have this? How do you know? Are there any foolproof ways of knowing as much as you can before a baby's born, I mean, other than an ultrasound?
The ultrasound is definitely the first line. There can be other studies like a fetal MRI, but as far as congenital heart defects go, a fetal ultrasound and a specialized ultrasound of the heart called a fetal echocardiogram, between those two and with both of those, a heart defect should be diagnosed. So going to your question about where to get a 20-week ultrasound, as Dr. Lindley said, if you have certain risk factors like congenital heart disease yourself, then being at a specialized center is recommended. But frankly, most women don't have that history, and actually that's where most pregnancies with heart defects occur, are in low risk mothers. So no history, family history of a heart defect, and most all of those low risk women are seen at the general community, either at the local hospital for their ultrasound or at their obstetrician's office. And so what we at the Fetal Heart Center really try to emphasize, because of the low risk pregnancies is where most of these defects will occur, is to help educate and teach and train sonographers, the obstetrical sonographers, really how to do those good screening views. Because again, at that 20-week ultrasound, most of the critical heart defects should be identified. So really, if I were advising a patient wherever they live and whatever OB office they're going to, what should I know about the fetal heart before going in? I would say make sure that they look and identify 4 heart chambers, but also that they look and identify the outflow tracts, the aortic outflow tract and the pulmonary outflow tract, which again really is the standard. It's the recommended standard guideline, but practically speaking, not everyone's able to get those views all the time, and so to sort of be savvy about asking about those 2 views in particular.
And we talked about this with the fetal echo as well, but with the ultrasound, don't be surprised if a doctor cannot get a good 4-chamber view. They should ask you to come back and get that look.
Right. And the outflow tracts as well, and sometimes the babies, are moving a lot. It's hard to see it at earlier gestation. An ultrasound at 22 weeks it's easier to see the heart structures than at 18 weeks, frankly. And so the 20-week ultrasound can occur in that time frame. So yes, if they can't see it all, either to come back in a short order, like in a week, or to refer on for a specialized look at the fetal heart.
Okay, and while we're looking at the heart, Dr. Villadel, there are a number of issues that could come up. In the case that we saw earlier this week, it's tetralogy of Fallot was the scientific name for it. Can you tell us a little bit about the different kinds of congenital heart diseases, congenital heart defects that you track patients with as time goes on?
Sure. Well, tetralogy of Fallot would be a typical one. We've probably seen hundreds of patients. It's relatively common. And tetralogy of Fallot happens to have a very good prognosis. A number of them will need another operation, particularly on the pulmonary valve as adults. And we've done many, many of these. It generally goes very well. Patients with tetralogy have an excellent prognosis. We follow a number of them, and they generally do very well. There's scads of other terms and other types of congenital heart disease we follow, but that one in particular is very rewarding for us to follow.
And
Because the
so-
patients do so well.
I'm
long term.
trying to think of the simplest way to ask this question, or have the simplest way to have you answer it, so that we'll all understand, even without any sort of medical background. The heart obviously pumps blood to your body. Tell us a little bit about what it does. I mean, I know I hate to be the Captain Obvious here, but I think it really does help to have a full understanding of what the heart does and what could be wrong that would indicate something.
Well, the heart has, as Dr. Lee mentioned, 4 chambers, 2 great vessels, and also 4 valves. So any combination of that can be a problem. We can have valvular disease involving any combination of heart valves, and also in embryology, not all the time do the 4 chambers form well. So we have a number of patients who have only 3 chambers, for example, what we call univentricular hearts. So there's a whole slew of things that can go wrong in embryology, affecting either the chambers, the heart valves, or even the great vessels. The great vessels, normally the aorta comes off the left ventricle and the pulmonary the right. That can be reversed, and we call that transposition. That's another common condition that we follow from fetus into adulthood. We have hundreds of patients with transposition of great vessels that we follow. But any combination of defects, that's why it's such a fascinating field, congenital heart disease. Any combination of defects can and does happen.
And I will also note you're hearing some noise in the background here. We are near the landing pad for the helicopter, so occasionally there is that extra buzz that you'll hear in the background. So it is not something wrong with your computer. But with these diseases, okay, let's fast forward to after baby is born. And in this case that we heard so much about, the baby was diagnosed because a nurse heard a murmur. And I think everyone looks at that and thinks, thank God that nurse heard that murmur. Is that the only thing that would indicate that there was an issue post-birth, or are there other tests out there that would automatically be administered to any newborn baby to indicate greater problem?
So a murmur, as you mentioned, is a common way that heart defects can be picked up. A murmur just means an extra heart sound. So in addition to the normal heart sounds that we hear with the stethoscope, the physician or nurse hears an extra heart sound. A lot of times it can just be normal as the baby transitions from being in the womb to out of the womb, but sometimes it can signal that there is an underlying heart defect. So a murmur is one way. I think Jimmy Kimmel also mentioned the color was different. That wasn't really apparent to the parents, but people who see a lot of babies know when a baby looks a little duskier, and so which can reflect a lower oxygen level. And so by checking a pulse oximetry or an oxygen saturation, when we'd expect it to be 99, 100% in a normal baby after transitioning out of the womb, it would be lower than that. So it could be in the 70s, 80s, or low 90s. So those can be tip-offs, or if the baby's having some respiratory distress, is not breathing well, or is really irritable or not feeding well, can be some signs. But even if a baby can look really well and still go home with a heart defect, but fortunately now in most states, including Missouri and Illinois, all babies or after 24 hours of birth undergo a simple non-invasive test before discharge called a pulse oximetry screening, where their oxygen saturations are checked on their right hand and one of the lower extremities, on one of the feet, to make sure that the oxygen levels are okay, because sometimes, again, a dusky baby may not be apparent just by looking at them, and so we actually check their oxygen levels.
And that's legislated in Missouri, is it
And
not?
Illinois.
In Illinois, okay, so
Yes.
all babies do
Yep.
receive that.
Mhm.
And have you seen in your practices that be of you, I mean, does that come back with information that would indicate that a child needs to wind up in your care?
Yes, definitely. So if a baby does not pass that pulse ox screen, then the next step is to get an echocardiogram on the baby themselves, so an ultrasound or sonogram of the heart to look. And it's not always, even though the baby does not pass that pulse ox screen, we have had normal hearts, but we have definitely picked up heart defects that way.
Okay, and let's just go down the line in terms of what treatment is involved from childhood into adolescence and into adulthood. So what are the first line treatments for a child who is diagnosed with a congenital heart defect, knowing, of course, that it varies based on diagnosis?
So as Dr. Biladella mentioned, depending on the spectrum, whether it's mild or moderate or more complex, it depends on how we approach it. But from my point of view is a focus on an early diagnosis in utero. The main thing we're trying to do is pick up critical heart defects, so babies who will need intervention soon after birth, or so that again they can be delivered close to a center. And those babies who have those more significant heart defects may require medication, an IV medication called prostaglandin after birth. I imagine Jimmy Kimmel's baby needed that for the problem that he had to keep a certain blood vessel open, a fetal blood vessel open called the ductus arteriosus. So that's a temporizing measure until we can do either open heart surgery or a cardiac catheterization intervention to stabilize the circulation, to make sure the baby's got enough blood flow to both their body and to their lungs.
And of course, we see these children who a number of them have surgery in those first, as soon as they're strong enough, depending on whatever the case may be. And then they come back later and require follow-up care throughout, but they do very well. And then by the time they're adolescents, they wind up with you, Dr. Lindley, and there are so many issues that come with adolescence that, you shouldn't drink, or you shouldn't drink when you're an adolescent anyway, but drinking, smoking, birth control, all of these things are significant issues if you have heart disease. So can you talk a little bit about the treatment that your practice gives patients?
Yeah, absolutely. I mean, I think adolescence is a really difficult transition period, even if you don't have a heart defect.
Mm-hmm.
And I think growing up with a chronic medical illness really just adds to the difficulty of that transition. And so I think a really important thing is to recognize that most of these babies grow up and often have relatively normal childhoods, but they do require continued care into adulthood because they can go on to develop other problems later down the line. And one of the things that I see a lot of is, as young women are growing up into teenage and into their 20s, they start wanting to think about whether or not it's safe for them to have a baby. Can they have a pregnancy? What methods of birth control are safe for me? And so they really sort of develop these new issues that they didn't necessarily have during childhood that are really important to address. And so certainly there are some methods of birth control that are not safe for particular patients with congenital heart defects, and there are other methods that are very safe. And so we do actually have a lot of different options that we can offer them, but we want to make sure we have that opportunity to discuss with them what the options are. And then ideally we like to use those methods of birth control to help them plan out their pregnancies so that we can make sure that the mom is optimized before she becomes pregnant. We prefer for the mom to have preconceptual counseling with a cardiologist, a geneticist, a high-risk obstetrician, so that they're really well informed before they start on this journey of pregnancy. And then we work very closely alongside the maternal fetal medicine specialists and the anesthesiologists throughout the pregnancy to help prevent heart-related complications or identify what they may be. We manage their medications. There are certain medicines that are safe in pregnancy, certain ones that are not. And then another really important thing is thinking about whether or not having a normal vaginal delivery is safe for mom, whether it's safe for her to have a delivery at her local hospital, or if it would be better to have it here at a larger center. So we really kind of work through the whole spectrum with those special needs of young adult patients.
And male or female, a lot of these patients wind up then as 30, 40, 50, 60, 70-year-olds who require still continued care because this is a lifelong condition, am I correct?
Yeah, so just for example, talking about tetralogy of Fallot, too bad Dr. Rectasati's not here. We had a 75-year-old woman recently who required another operation, which Dr. Rectasati performed, and it really helped improve her quality of life. So even taking it to age 75, an active woman who was having problems, wanted to be more active, we were able to address that and help her.
And I think that leads into a really important point. You work at Barnes-Jewish Hospital. You're all Washington University physicians, but you work in different buildings in this campus. But you, at some point, may very well all see the same patient along the lifespan.
When patients transition, I tell them we're friends. they may in fact be seeing their pediatric cardiologist again. For example, a woman who becomes pregnant might go to see Dr. Lee, or a patient who needs an operation may see Dr. Entisati. So we're very much a continuum. The buildings are connected. We're friends. We talk to each other.
And that care, it's important, I think, to know that it's nice to be able to know that there is a place where you don't have to move from one place to another.
No, well, that's the concept, I'm sorry, of our center, is that it involves pediatric cardiologists, adult cardiologists, likewise surgeons, pediatric and adult surgeons. That's the concept of our center.
And another thing that's a major issue around here, and something that's very important to our physicians, is that you're not just doctors, you're researchers as well. So what kind of research is being done right now to improve the care of patients who are diagnosed, no matter where along the spectrum, with congenital heart disease?
Well, our group's been very active, and we actually collaborate quite a bit between the adult and the pediatric sides. There are several projects that are kind of in the works and that have been done over the last few years. Just a few years ago, we published a paper looking at the use of birth control amongst our adult patients with congenital heart disease and what their understanding was of what methods were safe for them. And we found some really interesting data, and it kind of altered the way that we approach the subject. And as of now, we're currently looking at how our patients do with pregnancy with certain congenital heart defects. So I think there's a lot of unanswered questions as the adult population is really growing, as surgeries have been successful and babies are doing so well.
And it's a population, when you are looking at the adult congenital heart population, that it's a strange thing to say, but it's exciting that it's growing, because that means that these children are growing up. And I look at research also, and correct me if I'm wrong, but I'm going to assume, Dr. Lee, that your area of focus has evolved tremendously over the last few years.
Right, it is. The ability to diagnose into, as far as technology, our ultrasound probes, our machines, our ability to detect earlier, that's been really exciting, and to be a part of that. And as a pediatric heart center, we're involved in different projects, different collaborative groups. So as we've talked about, survival has improved overall in the field of congenital heart disease. And so in addition to survival, we, on the pediatric side, have start to focus a lot on quality of life, both for the patient themselves, neurodevelopment, psychosocial kind of quality of life, but also for the family, for the parents who have to take care of the baby who may need operations, multiple interventions as a baby. So our heart center is involved in numerous collaboratives, looking at different patient populations, and also on a neurodevelopmental level with other pediatric heart centers.
So much information that we have gained already, and it's exciting to know that there is still so much out there to learn. And we have some questions coming in from those who are watching us today, and this one goes to, I think, not pre-existing condition, something that would predispose you to a heart condition. This, someone typed in, Dad had a heart attack. Can his daughter have heart disease and have a hard time when she gets older? So that maybe isn't, I'll let you actually before I...
It really depends. If Dad had a heart attack at an early age, then yes, it would put his children at risk for that. And we would recommend cholesterol screening, for example, perhaps consultation with an adult cardiologist. Those patients whose parents have heart attacks at an early age are at risk.
Okay. And we had a comment from someone who's had a grandson with truncus arteriosus. Can you explain this condition? So I'm not sure who to look for that one, because I don't know what that is.
Truncus arteriosus is one of the critical heart defects. It's one that typically requires an intervention within the first week or month of life. So as I mentioned before, we look for on ultrasound 4 heart chambers and 2 outflow tracts, 1 to the lungs and 1 to the body. In truncus arteriosus, although they have 4 heart chambers, they have a large hole between the 2 ventricles or 2 pumping chambers, and they have a single outflow tract that supplies blood both to the body and both to the lungs. So that also can be picked up before birth, again by taking the extra step to look for the outflow tracts, and a doctor, a sonographer will see there's only 1 outflow tract.
Okay. All right, and another question is, what are your recommendations? And I think that maybe each of you might have a little something to say with this, but the message is probably going to be similar. What are your recommendations to keep a healthy heart regardless of your situation, particularly if you have a family history or indication of congenital heart disease in your family? And we'll start at this end and move our way. So Dr. Villadello.
Okay, diet and exercise.
I was going to say, is that going to be the same answer along the way?
The other thing that I would add to that is if you don't smoke, don't start smoking. And if you do smoke, it is hard to quit, but you can do it. And it is the number one thing that you can do to protect yourself. It's really the leading cause of heart attacks in young women is smoking.
Interesting. Even now that we know all of this information, that's surprising to me. But I think we all kind of have that sense that it's not going to happen to me, but you see patients all the time where it does.
It's true. What we know is that most patients, and especially most women, tend to underestimate their own risk of developing heart disease. And so it's important to really kind of take control over your own health. And, there's some things you can't change, like your genetics or your gender, but there are things that you can modify. And so you can do what you can to help reduce your risk.
All right. Diet, exercise, don't smoke. Anything else to add to that one?
Those are the main things. I mean, and that applies to children with congenital heart disease as well, that we do so much to try and optimize their survival, and as they go into adulthood, I mean, those same things apply. We want them to be active and but also not be overweight and smoke and increase their risk factors after all the work that the family and the peds team and the surgeon has gone through to help them their survival.
And all of this is extremely stressful on a patient, on a family. Are there resources out there for people who are maybe going through this and feel like they just need a little extra support?
Yeah, absolutely. I mean, I think one important thing to know is that you're not alone. If you have a congenital heart defect, or if you have an acquired defect, or if your family member has that, and there certainly are a lot of resources out there. There are definitely some support groups on the pediatric side that are very active, and we're actually in the process of developing some support groups from the adult side as well. So we'd really like to work together to make sure that the patients have all that support that they need.
Just to put in our plug, our nurse practitioner, Amy Mueller, is actively starting up a support group for adults with congenital heart disease.
Again, it's nice to be able to stress adults with congenital heart disease. I cannot believe we're saying that as a positive thing, but to know that the babies that you are first introduced to when they are a pound, if that, grow into adulthood and live very, very full lives and very healthy lives. So thank you all so much. I don't know if we have any other questions coming in, but I think that's it. So we will wrap it up there. Thank you all so much for joining us. We appreciate your time. And this will remain on our Facebook page. We'll put some resources in the comment section. And if you have any additional questions, please feel free to punch those in along the way. We'll